So officially, hello everybody. Today we are happy to have Professor Fischer with us. Professor Uwe Fischer, you know, everybody is, many of you know Professor Fischer as an expert in multimodal concepts of early diagnostic in the breast cancer. And most of us have a teaching book from Professor Fischer on imaging and interventional is our table book for all radiologists and mammologists. So your books are translated in many languages, and still I want to say that still the main problem is breast cancer surviving and early diagnostic. So this is a very important question, so we need to have better instruments. We have to have better. We have to better use these new instruments. These instruments is our weapon that we can help more women to survive. And so it's my big pleasure today to have you, Professor Fischer, with us, because we know you are expert in these multimodal concepts of early diagnostic, and you are author of Göttinger OptiPark, so it's a very special tool in the early diagnostic. So I'm happy to have you today, and so I give the word to you. Welcome.
Okay, thank you very much, Dr. Popovic, and thank you very much to all the colleagues and participants. I think we would like to go for the next 1 hour, or let me say a little bit more, maybe, to speak about the ways we try to find breast cancer very early. And for this time, I would like to talk about the ways we have in Germany. We have concepts for different groups of women, and we have different tools, and this is what I would like to present now. And I will give my screen free for you. Before I start, if anybody of you has a chance to get an influence to this war in Ukraine, let me say, because we are very depressed by the situation, if there's a way to stop it, do your best. It's a message for you all. I would give before I start with my presentation. So presentation, breast imaging, how we do it in Germany, how we try to find breast cancer very early. This is for me my life. All the time I started in the University of Göttingen. You see, Göttingen is in the middle, in the heart of Germany, between Hanover and Frankfurt. It's a small university town, but the university, the medical part of the university, has a good history. I think I switched in 2003 to a private practice, to a private department close to the railway station, and actually we are about, let me say, 8 doctors dealing with imaging of the breast. We have 2 MRIs running all the day and 1 MRI only for the breast. So this is the topic for us, MRI of the breast, and I will talk about mammography, ultrasound, and in MRI. So we do it. 3 points I will present. One is the different concepts we have for early detection of breast cancer. Point 2 is the actually used imaging tools, the developments on the base of digital mammography like tomosynthesis and things like this for early detection, and at least a very short part to the percutaneous biopsies, interventions, localizations in case of BIRATS 4 or BIRATS 5, when we need a histology of the lesion we found. So some information before breast cancer is very important. The incidence in Germany per year is about 75,000, and the mortality is close to 19,000. This is, let me say, very, very topic in the group of malignant diseases we have in this country. You see, we have different lifetime risk groups. The normal risk profile means that women have a lifetime risk of 6 to 8%, and we have this BRCA, this BRCA gene, women with an increase up to 80% of lifetime risk. In the average, we talk about 10% for women living in Germany to get breast cancer in their life. What means early detection? If I talk about early detection, this means we try to find breast cancer in the stage of intraductal extension, when the duct is intact, and we have to differentiate the high-grade type and the intermediate type DCIS. I think in a few years, in a couple of years, we will get a new definition for low-grade DCIS, because very, very often this stays intraductal all the lifetime of the woman. So this is one way to detect breast cancer very early. If the duct is left by the cancer, we differentiate stage PD1A and PD1B. This is early detected breast cancer when we talk about millimeter and not in centimeter. So a size under 1 centimeter is the definition for the detection of invasive breast cancer. Why is this early detected? Because the survival time for women with DCIS or small breast cancer usually have a long time living of about 95 or more %. There are some very aggressive types, you know, this triple negative grading 3 carcinoma, but there are only a few cases and a few women who belong to this type. If we talk about the palpable masses, if we talk about clinical examination, this means usually that the average size of the tumor is 2 to 3 centimeter, and we have a decrease of long-time survival. We can say that about 40% of these patients will die within the next 20 years if the size is in 2 to 3 centimeter or more. Diagnostic concepts we have, as I told, we have a group of high risk BRCA women with a very, very high risk. This is a separated group. We have screening programs. This is a political program that started in 2005 in Germany. It's quality assured, and I will talk about the conditions for this screening program in our country. And outside the screening program, we have the situation of an individual risk-adapted breast imaging. This is what we do in our institute. This means we are working outside the screening program. The other group, women or patients after breast cancer, the follow-up, this is also our job to find the tumor relapse or a metacronius second cancer very early. So all these groups are our job is to make early detection of breast cancer. And we have the group of symptomatic patients. When they came, they have a palpable mass or things like this. This is assessment, and these tumors are very often larger than we call it early detected. So I come to the group with a high risk profile. We start in this group with 25 years. What are the reasons to think about a high risk? We have this genetic reasons, BRCA1 and BRCA2, and other, let me say, changes to the genes. We have this therapeutic associated reasons. It's not so often the irradiation therapy in case of Hodgkin disease or things like this in young adults. And we have this familial disposition, and this has to be checked if this disposition means that the risk of breast cancer for the lifetime is more than 30%, or the risk to get breast cancer within the next 10 years is more than 5%, then the group of high-risk women is defined, and they go another way than compared to the women that have a normal or an average increased risk. What are the options of prevention for this group? We have the primary prevention, that means operations, it means to remove the oophorectomy and to make a mastectomy to decrease the risk to get ovarian cancer or breast cancer. But we talk about very, very young women. They are about 28, 33, 38 years old. The average age to get breast cancer with a BRCA gene is about 42 years old. So these men have family, young children, and it's not so easy to say we make a primary prevention. Most of them go the way of the secondary prevention. This means the intensified imaging concept, and I will talk about this because we have so much data from different studies in Europe, how it works when we perform different imaging modalities in this group. When it's made very well, we can get an average tumor size in this group by consecutive imaging with liquid modalities, invasive breast cancer with an average tumor size of 7 to 8 millimeter. And this is early detected, and the prognosis is very well for this tumor. However, this woman will have the risk at a second or a third tumor. This will not stop over a lifetime. What does it mean? Intensified breast examinations imaging. It's recommended to make a clinical examination starting with age of 25, ultrasound up starting with 25. Mammography is changed some years ago. We started with 30 some years ago. Nowadays, it's changed and switched to 40 because these BRCA women have a very, very high vulnerability against radiation dosage, and we have to stop mammography if it's possible for these women, for this group, because MRI of the breast, and it's recommended to perform it in Germany for high-risk women every 12 months, starting from the age of 25. And you will see this is a tool we have to use in this group, and we have to reduce the number of mammography to a minimum. I will show you some data from different studies. This started you can see in 2004, this nearly 20 years ago, from Crete in the Netherlands. You see yellow is a clinical examination, red is mammography. This is a sensitivity of around about 35%, and they had sensitivity for MRI of the breast, in nearly to 80%. Nowadays, we are much more better. For Germany, we have this IFA study. IFA, this means evaluation. There are 4 universities, and they performed a study. And now the yellow color is ultrasound, the red one is mammography. You see in this group of high-risk women, mammography has very, very low level for sensitivity, and MRI in this group is quality assured MRI, 99% sensitivity, and the specificity is in 1 level for all imaging modalities. I can go on. This is Milano, the hypocrite study from Zadanelli is really the same. We get about 50% with mammography or ultrasound, and if we make a combination of both, we will get 60 to 65%, but no more sensitivity with these tools. MRI was in another region with 92% sensitivity. There is a study from the working group of Vienna, nearly the same. And the last study I will show you is from Canada. They performed mammography and MRI, and in the summary, we can say we found the double amount of breast cancer when we use MRI compared to mammography in this younger group of high-risk women, because these women have usually a high density. I will talk about the density, the breast density later, and the problem of breast density for mammography. Some examples for high-risk examinations. This woman has been 48 years, so mammography is acceptable, and she has a suspicious lesion. We can detect because this lesion is surrounded by fat tissue, and this is not a very dense breast, so we have changed to see a mass or a lesion. We can use our ultrasound. This is ultrasound Biorets 4 to 5. We have criteria of a small malignant tumor, and we can see a lesion. This is an enhancing lesion in MRI, in contrast enhanced MRI. So with all modalities, we can depict this breast cancer. PT1B 8 millimeter, and typical for this group, grading C, triple negative. Another example, and this shows that MRI does not solve all problems, because if we have very small cancer, intraductal, maybe that this is associated with microcalcifications. You see in the mammography, even this mammography is very, very dense. The tissue is very dense. We can depict calcifications. This is no problem. This is domain of the mammography to say there are microcalcifications or there are no microcalcifications. This is very easy. And this is small group clustered pleomorph microcalcifications. This is Biorets, let me say, 4C or 4B. We have to clear the situation as this was DCIS, and there is no enhancement in the MRI. We cannot clear suspicious microcalcifications with MRI because the mammography that shows microcalcifications is superior to the information of MRI. And in this case, the diagnosis was possible because we used mammography. Ultrasound does not sign anything in MRI, does not show anything. This was grading to DCIS. Another high-risk women in the follow-up of MRI. So it's recommended to perform MRI once a year. This is a pre-MRI, and 14 months later, you see in the single slice that there is an increase of the size of this lesion. And this is enough to say this is Barrett's minimum 4. Maybe you can say 5. It means the same. We have to perform a percutaneous biopsy to clear this situation, to get a histology. You see the mid-presentation, all 50 single images are concluded in one image. This is a maximum intensity projection. And this is a breast cancer before. We cannot find it clearly because there are so many faults, there are so many spotty enhancement regions, but the follow-up will show us that there is a size increase, and this is what we do when we say these women have to undergo MRI of the breast every year. There was no associated finding in mammography. There was no finding in a targeted ultrasound. In all cases like this, we make a targeted ultrasound, knowing the localization of the lesion, knowing the form, knowing the size of the lesion, and we are looking for to clear the question: can we perform the biopsy ultrasound guided, or do we have to go the way with MRI? And there are other situations with very, very aggressive carcinoma. This is a young high-risk woman. You see the pre-MRI, and 16 months later, it's like an explosion. This is a small fibroadenoma we controlled for time, but this is a very, very aggressive breast cancer with rim sign and very strong growth within 16 months. This 18 millimeters, that's too much for early detection, but what shall we do? Even if she would be a little bit earlier in the MRI, this would be a very large tumor. Okay, there is a publication from Dr. Püsken from Köln some month ago, and he said for high-risk women, we should define a preference of imaging modalities. And this preference means first step to go is MRI of the breast in this group. The second step is mammography, maybe mammography not every year, even starting not before 40. And so what we do is we perform mammography every 3 to 4 years in addition to MRI, but not every year. And what we do is we make a one view examination of the breast. I will tell you later, not 2 views per breast to reduce the dosage, the radiation dosage for these women. And the last message, if we have some unclear, some suspicious lesion, however, we perform targeted ultrasound, as I told you before. So I will show you MRI of the breast if the quality is very high, and this has to be preferred because we have really a sensitivity that is much more than 95%, and we can exclude malignant tumor when we have MRI quality like this. All invasive breast cancer are associated with an increased vascularization and with an enhancement after application of contrast material. And if we see nothing, we have a very high sensitivity. And the question is, why do we perform an additional mammography why do we perform an additional ultrasound in cases like this? And this is our usual case. We perform about 20 to 25 MRIs of the breast every day. And this is what we wish to see. Then we can say it's okay, there's no breast cancer. There's nothing more to do. No mammography, no ultrasound examination. Okay, this is a group of high-risk women. Let me talk about the normal risk women that are invited to get a mammography in a screening program. This started in 2005 in Germany. It means all women between 50 and 70 years are invited to undergo a mammography in 2 views, bilaterally every 2 years. And the reading of the images is done by two readers. And if one of these both readers say, oh, there is something unclear, there is let me say the reader boss who will clear if the woman will be recalled to come again for ultrasound or a specific mammography view or however. And in Germany, the rate of participants in the screening program actually is 54 to 55%. The average detection rate for breast cancer is 75%. It's not 90%, it's not 80%, it's lower. And the reason has to be understand the detection rate is strongly depending on the breast tissue density. We differentiate these 4 types. We call it ACR density type A, B, C, D. Before we had 1, 2, 3, 4. They changed it in the Barrett's Commission, and ACR, this means American Congress of Radiology. This is these are the 4 types, and the detection rate for density type A, this means it's very fatty matose breast, is close to 100%, and even if we have glandular structures, it's very high, about 95%. The problem we have are the women with really dense or strongly dense breasts, and the detection rate decreases to 50, 40 or 30%. And in the average, the result is average detection rate of 75%. Our problem for mammography are the patients, the women with really dense breasts, type C or type D. And the part of women with this density is about 50% in the German screening. It's half and half. Half is has a high sensitivity and half has a decreased sensitivity. What's the reason? I will show you the C density type A on the left side, and if there is a mass, we can see it very well, and we have the problem in the very dense breast. And even in this breast, you can see if there is microcalcification. This is harmless, this is unsuspicious, but we can see it even in density type C or D, the calcification. But we have a problem to depict the non-calcified mass because the density of the parenchyma is similar to the density of the tumor. Okay. Some examples. This is a typical case for screening breast cancer. If you have good experience with mammography, it takes about, let me say, 2 to 3 seconds to say, okay, there is a small breast cancer. We can clear this. We can use ultrasound, find this tumor, and make a biopsy. This is even a clear situation if you are experienced. This is a bilateral breast cancer. This will find in a screening program. It's no problem, because this carcinoma is surrounded by fatty tissue, and we have a differentiation between the density of the tumor and the density of the surrounding tissue. So it becomes easy to depict. This is a small carcinoma, and even on the other side, you see this architectural distortion. This has to be cleared with additional ultrasound, or you can use MRI, however. Even microcalcification, as I showed you, this is a domain, this is advantage of mammography. Okay. If we have dense breasts, you see we have no chance to find breast cancer in this dense parenchyma when the breast cancer is not associated with microcalcifications. And there are, because we have the problem of the dense breast, there are created studies in the last years to increase the sensitivity in this situation. One study, this is a DIMASOS-2 study, started in 2019, is very, very expensive, as you see, to clear the question, will it be helpful to make an additional ultrasound in women with dense parenchymal structures? And we have this data, we have an increase if we make an additional ultrasound of around 10 to 15%, an increase of the sensitivity, but all in all, the total sensitivity will stay at about 60–65%, and that's not enough for a screening program, to my opinion. There's another study, is the mammography versus tomosynthesis, and the synthesized image of the tomosynthesis, and even started 2018, very expensive also. And in this situation, we have data. You see the study of Perskane in Oslo, increase of the detection rate per 1,000 screening women. If we use additional tomosynthesis, is about a plus of 27%. This is great. This is a good result. But however, we are in a range of around about 80%. We have a Boston study, increase of sensitivity by using an additional tomosynthesis of 16%. This is better than additional ultrasound, but we have really problems with the extremely dense breast. And the so-called dense study from Mrs. Bakker from the Netherlands, she made mammography in a screening situation versus mammography, and for women with dense breast, density type 4, so very dense breast, she had an additional MRI of the breast, and the situation was on the right side, increase of the detection rate per 1,000 participants of, let me say, from 6.0 detected breast cancers in 1,000 women to 16. And this is really great. And we have a decrease of the rate of interval breast cancer. This means the breast cancer within the next 2 years after the examination, after the screening examination, and we have a decrease of this interval breast cancer of around about 80%, from 5.0 to less than 1.0. This is really important. We need no ultrasound. In addition, we need no tomosynthesis in dense breast. We need contrast enhanced tool to clear this situation. Actually, there is, no, let me say, this is already published by Comstock in the USA, and it's initiated by Professor Kuhl from the University of Aachen, the so-called ABB study, or abbreviated study. They compared tomosynthesis in a screening situation plus the synthesized image from the tomosynthesis the single slices versus MRI of the breast in women with density type C and D. And you can see the detection rate 7 of 17 carcinoma with tomosynthesis, and all carcinoma in this group found with MRI. And the detection rate compared to 1,000 participants is 4.8 with tomosynthesis and nearly 12 with MRI. This is very close. These results are very close to the results from Dr. Bakker in the DENSE study. If we compare it, increase of detection rate 145 from 6.5 to 16.5, and the increase of detection rate per 1,000 is the same effect, as you can see at least. So what is planned in Germany? And this is planned within the last 8 weeks. I got the information they plan to extend the screening to start with 45-year ladies, women, young women, and to increase is from 70 to 75. I think from 70 to 75 is okay, because these women have density types A and B, and the mammography works very well. But if we extend to the younger ladies, and we have data from other screening departments, we will get a lower sensitivity than now, and we will get really high radiation dosage, because the radiation dosage in a woman with density type 4 is around 4 to 5 times higher than the dosage in a density type A. So we have to see this very, very, very critical, and we do not know if the decision is really clear, or if they will took it again and reduce it again to 50 to 70 as we have it now. So outside the screening, we have individualized and risk adapted possibilities to use our tools, and I will show you. This is a study from Christiane Kuhl from Aachen. She evaluated women with a density type A to D, all density types, and you can see if you use MRI in this group in asymptomatic women outside the screening, you will get the same results. Then inside the screening, there's no difference. We have cancer rate detected only in MRI. So let me say, in addition to mammography and or ultrasound of 50 to 15.5 per 1,000 women. And in the prevalence round, it's the time when the women come the first time. This is very, very, very high. In the incidence around the follow-ups 2 years later, this decreases to about 7 per mil more cancer seen only with MRI. Initial concept: if a patient has a very, very fatty breast, it's okay to make mammography. Even if the woman is older than 60 years, we have no problems with the radiation dosage. If we have density type B, mammography is okay. It's okay to find this breast cancer. The same situation than before. It's surrounded by fatty tissue, and it's easy to find it. Mammography. If we talk about women with density type C or D, it's not enough to use mammography alone. It's, let me say, too much to make more than one view. I think it's enough to make an oblique view in the situation. It's very important to have an additional tool. And the additional tool should be ultrasound as a minimum, and the additional tool should be MRI as an optimum. You see dense breast in this situation, maybe ACR type C or D. There is no chance to depict this carcinoma. I will show you in a single slice. This is very easy in MRI. You cannot, you must, it's a must to see it, no problem. Additional tool, let me say, I think in women with dense breasts, we should go the way to say first modality is MRI. And if we have a suspicious lesion like this, and we have the question, we need more information about the surrounding, are there microcalcifications, are there intraductal components in this invasive, small invasive breast cancer, then we have to use an additional tool, and this means mammography. The mammography is not the first, mammography is the additional, the second tool we have to use in dense breast. Very short time for the follow-up of patients after breast cancer. This is very clear, defined. If there was a breast conserving therapy, the recommendation is to perform mammography every 6 months for the next 3 years after BCT, and to perform mammography every 12 months for 3 years. These are the guidelines in Germany, and this is very, very difficult to explain a patient who had a breast cancer that was seen only with MRI and that was not seen and occurred in mammography, to explain this patient. You have to come every 6 months for mammography for the next 3 years. And she says, however, you haven't seen my breast cancer with mammography. Why should I come to mammography now in the next years? If a woman had mastectomy, it's easy. She has only the contralateral breast, and it's recommended to perform mammography every 12 months for the next 3 years, and later on every 2 years. But it's the same problem if there's a dense breast. We have this is a really problem. So follow-up after breast cancer, we have the problem I told you, the dense breast, yes, and we have another problem. We have this scar, and a scar cannot be differentiated against the tumor relapse if we have only morphologic criteria. So it's very difficult for mammography to say, is this a scar or is there associated breast cancer in the periphery or something like this? And even ultrasound is not able to clear the situation. This is very, very like yin and yang. With MRI, you see the scar in the T1 single slice, and there is no uptake of the contrast material. So you can say this is a post-operative scar. This is really no breast cancer. Another situation, you see the scar, the cutis retraction, you see the susceptibility artifacts, but there is no uptake of contrast material. And now I show you some post-operative tumor relapse T1s without contrast material, and the subtraction image. This is a clear situation. This is no inflammation or things like this. This is no fat necrosis. This is a really clear tumor relapse. Fat necrosis can be like this. If there is macroscopic fatty tissue inside the lesion, we can exclude malignancy. And in this case, it's very easy. There's no uptake of contrast material. However, after deep or tram flap, a deep flap, you see here this patient had a tumor relapse a very short time after the operation. There is a very strong enhancement after application of contrast material. So I will make a short excursion to the examination modalities we have. I talked about self-examination, clinical examination, and ultrasound. I will give information about the value of these methods soon. And we have mammography and we have MRI of the breast. What now is inspection and palpation. Does not bring any advantage of the women. It's okay for the patient to something like awareness, but we will not find cancer early. This excludes, we can exclude this. It's no sense to palpable the breast or to concentrate to inspection. It's the same with breast ultrasound. Even if you use subtypes of ultrasound like contrast enhanced duplex sonography or 3D techniques, there is no advantage of survival, but it's an important method in addition to mammography if we have high density. It's better to use ultrasound in addition to mammography in dense breast than to do it not, but for early detection, the single examination to use only ultrasound is not helpful. Even if you use the tools, as I told you, up to the automated breast ultrasound techniques, it's no advantage, no increase of sensitivity, but sure, we have a relevant increase of specificity. We can have a better characterization if we have a lesion. If we have found a lesion, we can better characterize it. So the relevant modalities for the early detection, and I mean early detection, as I told you before, we have mammography and we have MRI, and mammography does not work very well in dense breast, so we tried to increase this information in dense breast by using other techniques. You see the advantage again, if there are microcalcifications, this is very helpful to have the mammography, but only 50% of DCIS are associated with calcifications. Only 30% of the invasive breast cancer have calcifications. So these cases can be found by mammography, but if there are no calcifications, we have a problem. And we can see breast cancer very clear in fatty tissue, but only 50% of the women have a density type A or B. So this describes our problem. We have the limitations, as I told you, for high density types. And tomosynthesis tried to get better results, but in very dense breast, we have no fatty tissue, and even if we get small slices from tomosynthesis, we cannot differentiate a tumor within the very dense breast. It's helpful if we have density 2 or 3, B or C. I will show you here. This is regular mammography. This is a slice from tomosynthesis. We see two cysts with halo sign and other criteria of benign lesion. And if we show in look into another slice, we see this architectural distortion, and this has been an invasive breast cancer in this area. So if there's fat in the breast, tomosynthesis is helpful. Other situation, other case, you see the single slice of tomosynthesis, and this architectural distortion can be seen much more better than before. Next, this is breast cancer in this area, and I will show you the tomosynthesis. You see if there is fat in the part showing to the pectoralis, we can differentiate this spicula, but we have no chance to see the border of the tumor if there is no fat. I will show you this. This is very easy, even there are some calcifications in the middle, but this is no more possible. This is thematic of the fat tissue and the surrounding of a tumor. Cone breast CT has been evaluated for more than 1 year. This is a really good technique. It shows breast cancer in density type A and B. This is mammography. This is CT, one slice axial, and we can make reconstructions in all views you like, reproduce this tumor if you like, things like this for a demonstration or for the application with the patients. But the problem is also what. No. Let me see. Okay. It does not work. The tomosynthesis does not work in very, very dense breasts like this in type C and D. And the solution is tumor angiogenesis. And this is described by Judah Folkman in the beginning of the 70s of the 1970s. He made studies with tumor cells on the eye of a rat, and he made some clones on the eye of the rat, and he found that the normal arteries in the surrounding of the eye are building new vessels, and to feed this tumor, to give him blood and all these things the tumor needs for the growth. And this tumor angiogenesis, this is what we use to visualize tumors in dense breasts today. And we have different ways. One way is to use spectral mammography. This is, let me say, a dual energy technique. We have our usual mammography system, but we need another filter with copper and aluminium, and we make two views of the breast. One with the normal 20 kV energy, and one with around 45 to 50. One below the K edge of iodide, and one in a higher energy form. So from 20 to 50, one electron is jumping out of the iodide molecule, and this is what they can visualize in a bright white spot. So we make a low energy image. We can use it as a normal image. We do not see so much. We can exclude microcalcification, but no more. If we have the high energy image, we do not use it. We do not need it it's important to get the algorithm images, and the algorithm images show hotspots if there is an uptake of iodide contrast material, and they show no hotspot if there is no uptake. So for an example, we have the normal mammography, very dense, and you see a small hotspot. This has been a small breast cancer. So with contrast enhanced spectral mammography, we can find very small, very early breast cancer. Another situation after breast conserving therapy and clip marking, you see local density of the parenchyma, and there is a, let me say, very soft hotspot, but this has been a tumor relapse with an uptake of the iodide. I have another example. This is a normal CC projection. We have density type C to D. We have areas with very dense tissue. This is normal finding on the right side, and this is more breast cancer on the left side. This is how contrast enhanced spectral mammography works for dense breasts very, very well. And I will show you the information that can be given by contrast application, and the information that we do not have without contrast material. This is a suspicious group of microcalcifications, no problem to find. You see there, this is a native breast CT. We have very bad special resolution of this microcalcification. This must be much better in mammography, sure. And if we give a contrast material, we can see the large tumor, more than 2 centimeters, including these microcalcifications. We cannot see on the pre-contrast images, we cannot differentiate between the normal tissue and the breast cancer tissue if you do not use the contrast material. And the case from breast CT with a very small breast cancer is in this area. You have no chance to depict the small cancer, and it's so easy if you give contrast material to realize it. The problem of breast CT is that we can examine only one breast with contrast material, and actually they are working to develop a system with dual energy in breast CT so that we can use it one after the other breast after administration of contrast material. What we use contrast enhanced breast MRI, this is a situation in our department. This is a position of the patient on the table, feet first, breast compression, and examination time you see is per 50 slices, less than 2 minutes, with a special resolution of 2 to 2.5 millimeter per slice. The matrix we use actually is 672, and we have first examinations with 1000 to 1000. So this is a so-called million breast MRI with more than 1 million pixel and a very, very high special resolution. And if you see this image I showed you before, you have no idea if there could be a tumor or not. We can exclude it with nearly 100%. We can say this woman has no breast cancer. This image is made within a time of 4 minutes, examination measurement time, 4 minutes and 30 seconds. And this is what's called first pass. This is what we do. We have one pre-contrast image, then the application of the contrast material, and two measurements after the application, and then we stop it, and that's all. This is first pass. If we do not see any uptake of contrast material within this time. This means about 4 minutes after the application of contrast material. If there is no uptake of contrast material, there is no breast cancer. We can exclude it very, very reliably. And okay, you can make the next measurements if you like, if you find something there, but this is the definition of first pass. And this is what we see in first pass. This is a pre-contrast image. This is the first measurement after the application of contrast material. You see the uptake in this area. And to make it much more easier to detect lesions like this, we use the subtraction technique. And we have all criteria for a malignant tumor. We have morphologic criteria. We do not use any signal-to-time curve since more than 10 years, because all we need is morphology with a high spatial resolution. Like this, dense breast in mammography, no way to find a small breast cancer. You can see that that's easy. Targeted ultrasound was normal. This idea was taken by Christiane Kuhl, and she gave this technique a name, this abbreviated protocol. Abbreviated protocol means we have the subtraction image from the pre and the post-contrast images, and the subtraction are dealt into a maximum intensity projection, and this is enough. This is enough for the examination. This is short protocol, takes only 4, 5, 6 minutes all in all. I like to make a T2 measurement to get information about the water content or fluid content in the breast before the dynamics measurements are started. So all in all, these short protocols, if it's first pass or if you call it abbreviated protocol, means that we have a measurement time, a total measurement time for MRI of less than 10 minutes. That's what we wanted. That's the way we go for the future. And I show you a 1 million pixel MRI of the breast, and you see 3 breast cancer in the left breast. This is 5 millimeters. This is 3 millimeter. Okay, we can find this also in 1, 2, 3 years. We have a double time of breast cancer of around 1 year. If it's today 2 millimeter, it will be 4 millimeter next year, and 8 millimeter in 2 years. But this is what MRI is able to do, to find small breast cancer with a high reliability. Okay, and we do it consecutive. The recommendation to the women is come every 1 to 1.5 to 2 years. Usually the interval should be 1.5 to 2 years, and you see breast cancer in this image. This is what we found, and this was 2012. There was nothing. This was 2013. 1 year later, you see the breast cancer coming, but you cannot react to an uptake like this. But 1 year later, it's very easy to say stop. Now, this was DCIS. And another situation, you see the breast cancer in this area. This is the breast cancer. Same situation. 2012, there was nothing. 2013, this was a small focus. You can react if you like, but we have to be careful to decrease the number of false positive findings. So we have time. We have time to wait. You see 2014, we have an invasive lobular breast cancer, PT1A. This is what we want. all these cases are PNO, so the lymph node situation is clear. We have an evaluation. What happens if women undergo MRI of the breast every 1.5 or every 2 years? And you see we have a very high number of MRI, 8,900 incidence MRIs, so follow-up MRIs, more than 6,000. We have a rate of breast cancer. And if you see DCIS, PT1A and PT1B, so early detected breast cancer with a very, very excellent long time prognosis, make 80% of all the cancer we found. And if you look to the average size, if we have invasive lobular cancer, the average size is more than 10 millimeter. But the growth type of invasive lobular cancer is like a goose pattern. It's like small waves they make, so the size is large, but the tumor cell number is not so great than 12 millimeter, we'll say. Invasive ductal carcinoma, this is our usual found tumor, is about 8 millimeter in average size, and this grading 1 TC have 5 millimeter. We had a lymph node state of 96 PN0 in the group of the invasive breast cancer and an interval carcinoma rate of 2%. These were 2 patients, one was a 5 millimeter, one was an 8 millimeter. One became a protesis in the situation, and she had a palpable mass, and the other had a diet. She had her body mass decreased about 12 to 14 kilogram, and then she had a palpable mass in the upper inner quadrant. These 2 women with interval carcinoma. You see, if the interval of MRI in this group with all risk groups, we did not differentiate. The question was, what is the possibility
Damit
for
kann ich dir leider auf dem Mac nicht helfen.
Sorry, yeah. Okay. What's the maximal size a tumor can grow if the woman undergoes MRI of the breast every 1 to 2 years? And you see the most breast cancer were below 12 millimeters. This is a line of 12 millimeter. The tumors that had a size more than 12 millimeters were grading 3 triple negative carcinoma. I showed you a case before. And the invasive lobular carcinoma was a typical type of growing like this goose pattern. So these are the cases we do not want, but we cannot avoid. What's the maximum for breast the concept? This is a cutting optic. This means we would like to find intraductal breast cancer. We would like to find very small invasive breast cancer. The combination of one view mammography, usually MLO projection to show the microcalcifications in combination with contrast-enhanced MRI. Göttingen Optipac has low dosage because only one mammography. You can reduce the dosage of the mammography a little bit, no problem. We have the highest sensitivity compared to all other concepts, and we have the highest cost of the combination of one view mammography plus MRI is around 550 to 600 euro. And I have to point out that breast MRI has essential conditions. This means you need an open breast coil and you need a compression tool to avoid this moving artifacts. We have the minimum matrix of 500 it's better to use 600 or more up to 1,000, and it's very, very essential to have empathic staff, to have colleagues who can who make it easy for the women to go for 10 minutes for MRI in this system. Last point, give me some minutes, then I will finish. If we use the examination tools like mammography, like ultrasound, like MRI, we have to create a final assessment from the information of every tool and make a final complete BI-RADS type. And if this is BI-RADS 4 or BI-RADS 5, we have a suspicious lesion. We need percutaneous biopsy. If the lesion can be seen with ultrasound, this is what we do routinely. At the same day, we see the lesion. We have a pre-fire image. We have to documentate the post-fire image in 2 views. And this is very, very easy. 3 to 5 specimen is recommended. If we have microcalcifications, we have the option of tomosynthesis guided vacuum biopsy. This is very easy. However, it's an upgrade or upright technique, so the patient can see what happens with her breast. You have to decide if you use this technique. However, it's very easy, and we have to documentate that the microcalcifications are within the specimen. Easier for the patient is to lie prone on a table. Special tables for stereotactic vacuum biopsy system is created under the table. The patient cannot see anything. Same procedure, the same procedure with the specimen radiography. What I like very much is this system what to make specimen radiography after each specimen we have taken. So the specimen runs through a small radiographic unit. It's called Brevera, and the specimen is put in something like this. You see specimen 1, specimen 2, and specimen 3, and you get the information. Is there microcalc or is there no microcalc in real time, so we can stop if we have 2 to 3 specimen with positive calcification, stop, and we haven't goes away with 12 or 24 specimen as recommended in the actual guidelines. If a lesion is only with MRI, we have the option to use MR-guided vacuum biopsy. You see the situation. One woman is close to the patient, and is under the doctor here. You see different systems you can use. This is a tumor who has to be cleared. This is the situation within the intervention. This is the situation after biopsy. We have post and pillar systems to use. That's what we use. We like it, this post and pillar system. This is another system which can be used if you like it. Okay, that's what I would like to say you. That's my team. I say thank you for your attention and wish you stay mammophile. I think it's worth to make good diagnostic, to find breast cancer very, very early, as I told you, and we have the chance to decrease the mortality from 22% nowadays to a number of 4 to 5%, but it's very expensive, and we have to use MRI of the breast, especially for the dense breast. Thank you much.
Thank you very, very much, Professor Fischer, for this fantastic overview of all possible modalities. Thank you for sharing your knowledge, your experience, your data with us. It's very, very useful for all of us. And let me ask a few questions what we collect in our group 2 days ago. So maybe some questions are easier to answer, some other maybe need a little more time. So I start with a first one is the question was, what is a category of gynecomastia? 1 or 2 in Germany? How do you categorize it?
So the categorization is defined for women usually only because we talk about screening program and all is defined within screening program. So it's not defined for mammography in men. For us, we make a categorization by rates 1 if there is only fat in the mammography, and we make a categorization 2 if there is really real gynecomastia with tissue, parenchymal tissue, and sure, if there are microcalcifications or a mass that is suspicious as is 4 or 5, it's the same like we use for women.
Perfect. Thank you very much.
We have to be relaxed with all the systems. Also, don't be like a corset. They put over us with bios, and we have to do it very, very, very well. We have to be relaxed. Let me say, all in all, I had a participant to a session in Göttingen, and he said, Mr. Fischer, I have 3 ways. The patient is health, it's normal. The patient has breast cancer, or I do not know. These are the 3 categories we have, and this is, let me say, this is what we do every day. Let her go. You have to make a biopsy, or this is BioREDS 3, and I hate BioREDS 3 because it makes a woman very, very crazy. She has to wait 6 months, and if it's malignant, we waited 6 months to clear the situation, and if it's benign, she couldn't sleep very well for 6 months. So I have to avoid BioREDS 3 if it's possible. I have to say normal, go home, or is this a pragmatic way to say if there is suspicious lesion, we will make a percutaneous biopsy, point.
Thank you. This is very clear. The next question, I think you answered already in your presentation. It was an optimal strategy for diagnostic or screening of a dense breast. So I think you surely told us it is one view mammography and MLO, and with the combination with the MRI.
There are very, very novel recommendations from EUSOBI, the European Society of Breast Imaging, from, let me say, 4 weeks ago. And they say very clear, if you have a woman or a patient with dense breast, you have to inform her that there is another imaging modality that has no radiation dosage and that has much more sensitivity. They do not say, what about the costs? Who should pay it? And things like this. This is scientific group, but we have to inform women about the value of mammography, the limited value in dense breasts.
Unfortunately, we don't have this information in German screening program. I don't know why.
They will change it because this paper is from February or end of February. It's very, very new. And the screening has has to deal with this recommendation. They cannot say, okay, we are screening. We make a short information in the information paper. So they have to point it out more than in the last time.
Okay. Next question is some artificial intelligence in a breast MRI. Do we have some perspective in this field?
Actually, we have a study program together with Siemens, and we feed the system with 40,000 MRI of the breast. All we have done in the last 15 years. And this is, let me say, high quality, yes. And we have all histologies of the breast cancer. And it nowadays, we started 6 months before. I think it takes us 2 to 3 years minimum until we get some information if KE will help us. I do not know. I have no idea if this is an option for the future, because I see us as a radiologist, I think even for mammography, there have been CAT systems and things like this, but the best reader are we, and it needs us, I think. Maybe it's a little bit helpful, but it will not be the situations that KE will read the MRI without the help of a radiologist. No.
So we have a few years.
I hope.
So we don't lose our jobs.
Yeah.
Perfect. The next question was concerning intraductal papillomas. So we know that quite often there are multiple, and a lot of them are para-areolar and then always larger. But in the most of the time they are benign. But we have a problem with peripheral papillomas and too difficult to visualize them with our normal methods, so to say.
So what's the way to do?
Yes. What is the way to handle with these papillomas and how to identify them?
Yes, as you told, we have two types. This large papilloma, the risk to become malignant is lower than the peripheral small papilloma. The guideline in Germany is really clear. If we have papilloma, it has to be removed because it's a lesion with unclear biologic potential. So it's called, the pathologist says it's a B3 lesion, and B does not mean Barrett's, it's a pathologic classification. The question is, if I have a large papilloma behind the areola or things like this, that has to be removed, yes. But there could be a lot of small papillomas in the depths, in other segments. So what we do is, before the operation is done, all of these patients undergo MRI, because you see this small papilloma. If you have mammography density type 1 or 2, you can see this like small balls. I said to a friend, these are like small balls in a sock or in the duct. You can see them, but if there is density type C or D, there's no way to find it. But MRI will show all papilloma have an uptake of contrast material. And even most of them are benign, but the lifetime risk is about 20%. That's a problem. So the recommendation is, if you have a papilloma, remove it. And before you remove it, make an MRI to see, are there more papilloma? Then you should make something like a segmentectomy or a quadrantectomy to decrease the risk to get breast cancer 5 or 10 years later.
Thank you. And it was additional question, if you don't find any papillomas with, I think, ultrasound mammography and maybe even with MRI, but you have this discharge, bloody discharge from the nipple. What you will recommend to do? And cytology is negative as well. Cytology.
Yes, I know. The patient comes, she has bloody discharge. What we do is we have this small urine stickies. That's very easy to clear if the bloody discharge is blood, or sometimes it's like brown, or to clear the first question, is it blood or not? So, or you can send it to the cytologist. If it is bloody discharge, the first step to do, in former times galactography, but actually no more. The first examination for us is MRI. And if there is no corresponding finding in MRI, no corresponding finding in mammography, ultrasound, we do nothing and ask the patient to come again in 4 weeks. These patients have very often something like bleeding from the nose. To compare it, to explain it to her, there may be a small vessel that is damaged and it's blood coming out, but it's a temporary limited situation. If this is persistent, then we recommend a ductectomy, because if a woman has blood in her shirt every day for weeks, for months, she asks for an operation and says, please remove, but because I have problems with the situation. So your question, if we do not find anything, we do nothing and wait if it stops over the time.
Yeah, thank you very much. May I ask some more questions? Do you have some more time?
I have my tea and I have time.
Perfect. Thank you very much. So next question is a little bit philosophic. So the question is, we don't have in our countries this specialty radiologist, mammologist. So we have only radiologists, some who make maybe only ultrasound or only mammography without ultrasound or only MRI. So it's very separated. It's not like here in Germany. The question was, is it possible to somehow influence our Ministry of Health so that we will become this separate specialization like radiology, mammology, or what we should do, what do you think what we should do to achieve this? Maybe I can formulate it another way. How do you organize this further training like Weiterbildung in Germany to become the specialist? Who is responsible for this training?
In the past, it was done in the universities, because if before you could call you a radiologist, you had to see 500 mammographies together with experienced reader. Nowadays, it's a really very, very big problem, because there are so many women going into screening. And screening means, as I told you, there are 2 readers, and you can say to a new colleague, come to me, and you can sit close to me and you can see what I'm doing. But what are you doing? You say plus or minus. That's all you do. You do not describe the images. You do not think about the content. So you say that's not okay, minus, or that's all okay, plus, and bye-bye. And you get no information about your assessment. And that's the problem. You cannot learn mammography if you do not get the real histology or the let me say the real diagnosis. You make your own world. Your young colleague will be a copy of you, but you cannot learn mammography. You have to see 3,000 to 5,000 mammographies per year over a time interval of 10 years. That's the time you will become better and better and better with your experience. After 10 years, you are top. You cannot bring anymore. But in Germany, the problem is really the same that you have think. It's not possible to learn mammography in the routine with all this stress you have. If you do not know what should I do to come again in 6 months to make a percutaneous biopsy, I hope if I say this is all okay, she will not come in 7 months and say, look, I have a palpable mass. You haven't seen it before, and things like this. This is missing, and we need it to get a really good learning process in our mind. And we will get a really big problem in the next 5 years, because the older radiologists working in the screening are going out, and the younger one are not experienced. And in the university, there is no more breast diagnostics. This is really, there's no one is in the university working on MRI, actually, not really. It's a little bit tomosynthesis, but this breast imaging is very difficult to learn in 2020, 2022 in Germany now. And it's maybe the same problem to you. You can make hospitalization, you can make training, you can go to lessons that are even on congresses. You cannot learn how to interpret, how to assess mammography. Difficult, and you cannot say to your government, please, you have to order this. You have to give them a structure, an idea, I think, to make something like, I do not know the English name, Fallsammlung, to make a number of cases for training, let me say 500 cases, and the diagnosis is clear, and then you can say, okay, this is a training for you, and I will accompany you, young radiologists, and I will explain you what you can see, how it is to describe, and things like this. You cannot learn mammography if you're reading a book about mammography. It's not possible, I think. It's very difficult.
Yeah. So thank you very much. So we have some questions in our chat. I tried to translate some. What you can say about MRI of diagnostic of the scar after the operation? Is it useful method to diagnose the scar after the operation? So you told about, you show us one example of scar.
I think there are two things that are important. First thing is, please make the MRI before the operation. Make something, we call it a local staging. If a woman has a suspicious lesion or has a breast cancer, BIRAT 6, it's already clear this is breast cancer. Before the treatment begins, perform MRI to get more information about the breast and the contralateral breast. And if you have a clear situation before the treatment, usually the operation begins, you can wait, let me say, 1 to 2 years. You need no MRI, because if it's breast conserving therapy, they had usually the radiation therapy. Sometimes they had chemotherapy. So, and if you have staged it before, there is no chance for a small breast cancer, maybe you missed of 2 millimeter, to get really a great cancer within the next 2 years. If you see radiation therapy, maybe chemotherapy, and then you were looking for 1 centimeter, it's not possible. But 2 years after the operation, it's very, very sensible. It's a best method. Once a year for the first 5 years after the operation. We have this in-breast relapse, and this in-breast relapse is caused by a so-called extensive intraductal component. An invasive breast cancer has some ducts filled with breast tumor cells in the periphery, but the invasive cancer is removed. Some ducts are removed, but maybe one duct is not removed, and it takes 1, 2, 3, 4, 5 years. And from this not removed DCIS, what we call EIC, this is the reason to become in-breast relapse. So the first 5 years, I have to offer a yearly high diagnostic with MRI. Later, I can do it every, let me say, 2 years or something like this. It is the best method. I showed you some examples. If there's no uptake, it's a scar. If there's uptake, sometimes it's an inflammation, granuloma or something like this, or it's relapse cancer.
So I write you some thanks from our chat. Thank you very much for the presentation in your books. Danke, Professor. Thanks a lot. Yeah. Thank you very much. Thank you. Thank you. A lot of thanks. And
I thank you very much. And if you like, we can see us again, let me say, in half a year to a special thematic MRI or to implants or to biopsy interventions. It's up to you. I liked it very much, and I'm honored that I got this invitation from you to give this presentation. Best wishes to all.
Thank you. Thank you. Thank you for your knowledge, for this very important information in that time. And we will, I'm sure we will ask you to come once more, because this topic, MRI of the breast, is very, very important. And all our participants ask us, maybe Professor Fischer can tell us more about the MRI, like a few lectures, but we can contact you after our webinar and to discuss this possibility.
I think it would be interesting to get more information about how we read MRI. What's the criteria to say this is benign? What's the criteria to say this is not benign? Things like this, because it's not so easy to read MRI. First, we have to get a high quality, no movement artifacts, and second point is to detect all these things and to make a correct characterization, even with this multiple footsie that people say, "Boah, I do not know what shall I do with this lady with this multiple footsie."
Yeah.
Okay.
Dear Professor Fischer, thanks a lot for your great lecture. Would we like to choose the best question from the participants of our webinar to present our little present?
The best question.
The best question, yeah. Which
the
one?
most interesting question for me was a question for the papillomas.
Great. Thank you.
Because this is clinical radiology. This is what shall I do when, ... And this is papilloma is very, very hot topic, yes.
Great. Thanks
you
once
very much.
again.
Okay, I thank you for your interest and your attention, and stay healthy. Bye-bye.
Yes.
Thank you,
Thank you.
bye-bye. Have a
Thank you.
nice evening.
Bye-bye.
Спасибо большое, друзья, я считаю, что прекрасный доклад профессора Фишера. Как всегда, он в прекрасной форме, в хорошем настроении. Конечно, не получилось вопросы все задать в чате. Я видел, что там еще были вопросы. Может, на некоторые вопросы мы сможем ответить в письменной форме. Мы можем профессору Фишеру выслать их просто в e-mail и постараться получить ответы. Вот. Ну, а так, всем еще раз большое спасибо. Видите, профессор Фишер согласился с нами встретиться в будущем, рассказать больше про МРТ молочной железы. Я думаю, что, наверное, лучше, чем профессор Фишер, никто нам об этом не расскажет. Вот поэтому будем очень его просить, чтобы он в ближайшее время, может быть, с нами встретился и более подробно раскрыл эту тематику. Вита, дайте слово Вите.
Да, сейчас, Вита, включаю вас.
Я хотела сказать, может быть, Сергей, если у нас есть время, ответить на вопросы, потому что там реально интересные вопросы и по МРТ. Я думаю, что вы тоже компетентны достаточно, чтобы отвечать.
Давайте. Можно прочитать вопросы тогда? Кто-нибудь прочитайте.
Так, первый вопрос. Чувствительность и специфичность контрастной маммографии и МРТ при дуктальной карциноме, когда видим кальцинаты по типу слепков, одинаковый? Вопрос. Или все же МРТ информативнее?
Ну, мы видели слайды профессора Фишера, он приводил там несколько исследований, не помню, как они называются уже, да, когда он сравнивал маммографию и маммографию плюс МРТ. Если это имеется в виду, то здесь, конечно, маммография плюс МРТ практически больше 90%, некоторые исследования показывали 92%, некоторые даже 98%, в зависимости от риска. То есть он еще разделяет, если мы смотрим женщин обычного риска и женщин высокого риска, да, то есть там немножко разные параметры, но комбинация МРТ и маммографии однозначно порядка 95% чувствительность и специфичность достигает. Поэтому если я ответил на вопрос, то комбинация методов, конечно, она оптимальна. Даже УЗИ в комбинации с маммографией добавляет только около 13%, да, мы находим больше карцином, а при комбинации маммографии плюс МРТ 200 до 240%, да, у нас, по-моему, доходило. То есть мы находили не 6 карцином на 1000, а до 17 карцином на 1000. Я не стал уже задавать вопрос профессору Фишеру про overdiagnostic, ну, это... То есть мы находим эти 17 карцином, но какой бенефит будет иметь женщина, влияет ли те карциномы, которые мы находим больше, на продолжительность жизни, на снижение смертности, да? То есть не находим ли мы карциномы, которые прогностически не влияют на снижение смертности от рака молочной железы. Не найдем ли мы эти карциномы низкопролиферативные, Г1 карциномы через 2 года на той же маммографии, и повлияет ли это, ну, он не смог бы нам ответить на этот вопрос, потому что таких исследований нет. Но я думаю, что здесь очень много overdiagnostic, это гипердиагностики, да, поэтому сколько мы не можем пока сказать, но однозначно здесь есть такая проблема.
Спасибо большое, Сергей. Как узнаете о женщинах с высоким риском? Где они проходят тестирование? У онколога, перед маммографией?
Да, хороший вопрос. Женщины с высоким риском, во-первых, гинеколог на приеме выясняет, есть ли у женщины семейный риск рака молочной железы, то есть если родственники первой линии заболели раком молочной железы и в каком возрасте, очень важно, и родственники второй линии, например, тети по материнской или по отцовской линии, и тогда собирается какая-то общая картина. И если у нас есть такая табличка, которая висит у нас в кабинете, ну или мы уже ее знаем, да, то есть, например, если у нас минимум 2 родственника по одной линии заболели раком молочной железы, и один из этих родственников младше 50 лет, ну, условно, заболела мама в 55 лет, и сестра мамы, например, в 49. То есть у нас уже 2 родственника по одной линии есть, и один из родственников заболел меньше 50. В этом случае риск заболеть женщине, которая вот сейчас у нас на приеме, около 20%. И в этом случае мы отправляем ее на специальную консультацию к называется Human Genetic. И там уже составляют такое родословное дерево, смотрят еще другие карциномы, там поджелудочная играет роль, предстательная железа, да, то есть это все собирается, где-то час длится эта встреча с генетиком, и женщина рассчитывается ее индивидуальный риск заболеть раком молочной железы. И если он достигает порядка выше 20%, а в этом случае он уже будет выше 20%, тогда у нее берут кровь на анализ. А вот этих мутаций, о которых говорил профессор Фишер, там порядка 9 мутаций. И дальше уже идет анализ, есть повреждение генов или нет повреждения генов.
Еще один вопрос. Как убеждаете в итоге женщин проходить маммографию каждые 6 месяцев после CP, СР, вот я не знаю, как это расшифровывать, к сожалению, у которых рак нашли по МРТ?
Сейчас я пойду. Вот, каждые 6 месяцев после CP. Проходить женщин маммографию каждые 6 месяцев после...
Юлиана, если вы еще с нами, можете голосом прокомментировать?
Секторальная резекция.
Окей. Нет, смотрите, на самом деле я не знаю, откуда эти данные у профессора Фишера. Эти данные были года 3-4 назад. Сейчас мы назначаем первую контрольную маммографию через 6 месяцев после лучевой терапии. То есть лучевая терапия, вот конец лучевой терапии, последний день. Следующий контроль через 6 месяцев с маммографией. И мы делаем обе молочные железы, маммографию в 2 проекциях. Это первый контроль. И дальше ежегодный. Раньше были такие рекомендации 6 месяцев на железу, которая была оперирована. Сейчас мы тоже иногда это делаем, если высокий риск. Если риск невысокий, то мы делаем раз в год маммографию с 2 сторон в течение 10 лет. После 10 лет, если нет рецидива и если в семье нет ни у кого рака молочной железы, тем критериям, о которых я говорил, тогда мы можем сказать женщине: окей, вы выздоровели, у вас нет рецидива, считается, если в течение 10 лет нет рецидива, женщина полностью выздоровела. Такие критерии в Германии. И она может приходить, она сама может решить каждые 2 года на маммографию, то есть как обычная здоровая женщина. Что касается вот эти раз в 6 месяцев, да, действительно, если высокий риск, мы иногда тоже рекомендуем раз в 6 месяцев на грудь, которая была оперирована, и раз в год здоровая грудь делаем маммографию. Как мы убеждаем? Мы говорим, что есть такие рекомендации, что у вас был высокий риск, и нам желательно смотреть чуть чаще именно железу, которая была оперирована, для того, чтобы мы вовремя увидели возможный рецидив.
Так, Сергей, я тогда продолжаю зачитывать, да, или вы сами можете в чате сейчас посмотреть?
Да, я могу сам посмотреть. Тут еще вопрос был дополнительный. У кого рак нашли по МРТ? Да, это, конечно, сложно, как профессор Фишер уже сказал. Конечно же, желательно нам смотреть дальше на МРТ, но проблема, кто будет это оплачивать, да, то есть здесь сложности тоже в Германии свои есть. Здесь есть вопрос, который я хотел бы зачитать. Он был мне в личное направлен, я не буду говорить от кого. Вопрос такой: спасибо, Сергей, что несмотря ни на что не исключаете российских коллег из профессионального сообщества и делитесь знаниями. Я уже говорил и высказывал свою точку зрения на эту тему, и хотел бы здесь сказать, что ни в коем случае мы не исключаем никаких коллег, ни российских, ни украинских, ни казахских. Я считаю, что есть проблема, которая нас всех объединяет, и это рак молочной железы. И давайте в этом сообществе, в этих группах будем обсуждать действительно эту проблему, и будем думать о том, как победить и какими методами нам максимально справиться с этой проблемой. Да? И поэтому я считаю, что никого мы не вправе исключать. Мы все понимаем и поддерживаем всех, кто сейчас находится в тяжелой ситуации. И я думаю, что мы все с вами абсолютно адекватные люди, адекватно воспринимаем все, что происходит. Поэтому то, что нас объединяет, это здесь, это ранняя диагностика, это лечение. Мы будем продолжать наш проект. Я считаю, что он еще сейчас как никогда необходим. Вопрос о сравнении с контрастной маммографией с МРТ, а не обычной маммографией с МРТ. Вопрос сравнения с контрастным. Контрастная маммография с МРТ. Да, вопрос контрастной маммографии МРТ, как сказал профессор Фишер, очень хороший метод контрастная маммография. Она позволяет тоже практически сравнимо с МРТ видеть те небольшие изменения. Единственное, что мы не можем при контрастной маммографии посмотреть лимфоузлы хорошо и стенку, торакальную стенку. Да? То есть это небольшие вот такие вот ограничения, но в принципе очень хороший метод и абсолютно оправданно, если у вас есть такой метод. Почему нет? Мы не применяем в нашей клинике, но метод хороший. Правильно ли я, Вита спрашивает, правильно ли я поняла, что он предлагает маммографию женщин с высоким риском только после 40? Там вначале, да, действительно, он говорит, что после 40. Почему? Во-первых, до 40, да, он говорил про женщин с мутациями. Потому что у женщин с мутациями чувствительность паренхимы, то есть чувствительность самой молочной железы выше к радиационному облучению, и поэтому мы дополнительную нагрузку даем им и так с высоким риском, а мы еще и дополнительно делаем маммографию. Поэтому говорит, что вот молодым женщинам с мутациями мы не рекомендуем делать маммографию, а все-таки делаем МРТ, после 40 уже можно делать маммографию. И еще вопрос от Виты тоже. Как часто рекомендуют проводить МРТ для пациенткам с имплантами в качестве скрининга для группы высокого риска и нормального риска? Да, хороший вопрос. Я думаю, что профессор Фишер, наверное, тут может нам лучше ответить. Я не знаю, есть ли в этом разница. Мне кажется, что имеется в виду импланты после мастектомии? Нет. Попробуйте.
Имеется в виду просто импланты, которые поставлены для красоты женщинам. Вот. Ну, и они должны же тоже проходить какие-то скрининговые программы. Естественно, конечно, получается МРТ. Как часто его делать в плане скрининга? Женщину, в принципе, ничего не беспокоит.
Раз в 2 года. Раз в 2 года профессор Фишер говорил, что у нас, если мы раз в 2 года делаем МРТ, то у нас вероятность найти рак меньше 1 сантиметра 98%.
И даже для женщин вот с мутациями, с высоким риском совсем тоже все равно...
Нет, с мутациями там по-другому, там другая схема. С мутациями раз в год МРТ делается, каждые полгода маммография и УЗИ.
Маммография делается даже пациенткам с имплантами?
Да, конечно, конечно. Да, обязательно. Ну, только если мы сейчас говорим не полное удаление молочных желез, а просто импланты в качестве, как называется, не красоты, а...
Аугментационная маммопластика.
Да, 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 совершенно верно. Да, коллеги, спасибо большое за ваше участие, за вопросы. Мы очень рады, что профессор Фишер так нам подробно рассказал про все методы. Там можно было, конечно, на 2 лекции разбить его доклад, но я думаю, что мы обязательно его еще пригласим. Думаю, что МРТ молочной железы вообще интересная тема, и мало кто об этом говорит. Вот, мы будем его стараться подключать к нам тоже. Если вопросов больше нет, спасибо большое, Николай, вам тоже за техническую организацию. Вы постоянно вели переписку с профессором Фишером, согласовывали с ним все моменты, поэтому огромное-огромное спасибо тоже вам за поддержку.
Спасибо. Запись данной лекции мы еще обработаем, выложим на наш YouTube-канал. Если кто-то не смог подключиться, то будет возможность ее еще посмотреть. А так, всем огромное спасибо, что нашли время сегодня подключиться и провести этот вечер. Я надеюсь, полезно и интересно. Ждем вас на наших следующих вебинарах. Все, всем всего хорошего и до следующих встреч.
Спасибо.
До свидания.